Dear students, we'll discuss a topic which is very common, especially in elderly and adult who are diabetic. They will have very regularly food problem, legs and foot. It's quite common. More than 50% of individuals who are diabetic eventually lead into some or other problem in the feet and leg. So what this condition is, look at this, look at that, foot is there, see that yellowish area in the plantar aspect, see that must be an abscess. Here also destruction is there, see that. So second toe is, there is an abscess, some sort of ischemic destruction, maybe basically sepsis. And you can see the edema here, it is cellulite, with the cellulite extending. Abscess extending a cellulite is proximal into the foot. This is the localized collection. You know that abscess definition, all of you know, is very important. Localized collection of pus in a cavity lined by granulation tissue covered by pyogenic membrane containing pus in locally. Word localized is very crucial and important. Remember, so it is second to it is involving with an abscess. So causes are so many causes for a diabetic foot: increased blood sugar level, under controlled blood sugar, and microangiopathy, macroangiopathy, diabetic neuropathy. In neuropathy, there are three types: sensory neuropathy, where sensation is not there, so they don't feel any pain, especially in the plantar aspect. Any injury occurs, they won't come to know, so they don't clean it, and eventually infection occurs, abscess forms. Then only they will realize there is something wrong, because they won't feel it. Naturally, it is because in day-to-day our workup, we also don't observe and monitor our plantar aspect. The foot is the most ignored area actually. We won't look into that, anything is there in a day-to-day, anybody. And that is, we miss the infection because no pain there. And motor neuropathy occurs, so muscles are not acting well. Arches mainly, arches of the foot and longitudinal and transverse arches, 4 layers of muscles are there, joints are there, ligaments are there. So all this, because of motor neuropathy, these arches, its normal functioning is lost. So they are more prone for infection, sepsis, pressure sores, and so on, all those things, because of the non-functioning or inadequate functioning of the arches. That is becomes motor neuropathy, autonomic neuropathy. So dryness of the skin over the foot and leg occurs because of the autonomic neuropathy. Sweating will not be there. Oil, sebaceous gland or sebaceous secretion is not there. So oil won't secrete, and souping of the skin is not there. Dryness of the skin occurs, breaking of the skin, microtrauma actually occurs. You won't realize, they don't have pain, they don't feel the trauma also, because micro breaking also, and bacteria enter there, causes sepsis. So all these 3 types of neuropathies: microangiopathy, macroangiopathy, poor blood supply as such, and high blood sugar is a good culture media bacteria, and sensation, loss of sensation, everything adds on to this forming a diabetic foot abscess, a critical area actually. They'll have osteomyelitis of the metatarsal, 1 or 2 or more. Eventually blood supply goes and gangrene forms, sepsis occurs, recurrent sepsis occurs. Finally, they will eventually lose the foot or leg as such. So loss of limb occurs. So that is what exactly is very important, diabetic foot. So assessment in this patient is blood count, blood sugar, HbA1c, glycosylated hemoglobin, very important. Serum creatinine, sometimes there is a nephropathy, serum creatinine level estimation, and other X-ray of the part for osteomyelitis. Pus discharge is there, pus culture, and arterial Doppler with the B mode duplex scan. That's important. And angiogram, CT dynamic angiogram you can do. And if you want to do some intervention, conventional angiogram. For intervention, conventional angiogram is better. Whereas for assessment, CT dynamic angiogram is better, where you can see the site of block, level of block, femoroplopetal, ilofemoral, bilateral, unilateral, then extent of block, amount of collaterals, distal runoff. All those things should be discussed. For all these things that I have discussed in the angiogram film I have put, CT angiogram earlier. We can always scroll that. I also discussed peripheral arterial disease, live session we had, as well as we had small peripheral diabetic gangrene, arterial gangrene, ischemic gangrene, short lectures we had earlier. You can always scroll back similar lectures so that you'll have the better knowledge. And see that X-ray showing osteomyelitis here. This is the X-ray showing the osteomyelitis. X-ray is a must in this patient. And currently, many people advocate MRI with a very clear picture of what exactly happening, the soft tissues, the stent, everything. So MRI may be better. See that when you open this one, when I opened it, bone is destructed. See, the bone is destructed. So this bone is removed. All those dead bone is removed. You know, that's sequestrum with the dead bone in situ that is being removed. And pus also drained properly. And incision drainage and distal planks is removed. Antibiotics is important. Always start antibiotic. Control the blood sugar. Do the urine ketone bodies also. So care of the feet. Always you have to start insulin in this patient because oral medication is not sufficient because pus is there. And microcellular rubber chappal to prevent the further pressure source over the plantar aspect of the foot. And so that is about diabetic abscess. So you can always go through my SRB's manual of surgery and clinical methods in surgery for a detailed examination and overview of the diabetic abscess, which is very common theory question. Viva they will ask, MCQ they will ask, NEET exam they will ask, Oxy they will ask in your exam. So that is very important topic, very common entity to remember. So students, answer the MCQ. Common site of diabetic ulcer is medial malleolus, lateral malleolus, head of metatarsals, head of toes. Put the right answer. I will acknowledge your answer and get back to you. Answer the MCQ. Parameters for L-Renex scoring system for necrotizing fasciitis is A, B, C, D. I will put the right answer and I will get back to you. I will acknowledge your answer. Quotation of the day is: life alternates between pain and pleasure, but none of the two is important, permanent. You will have sometimes sorrows, difficulties, problems, and sometimes you will have a happiness in the life. It's a balance between the pain and happiness. Always, it is a ups and downs. It's always there in everybody's life. So always you have to balance between happiness and pain. You have to accept these two. These are part of life. This is what exactly this quotation says. And the same, this holds good, very good for in surgical care. You will have difficulties in surgery, good outcome in surgery also sometimes. You have to balance between us, Sita Prajna. This is what exactly it meant. So students, again I request you to have my SRB's manual of surgery, current edition, SRB clinical methods in surgery with the videos of how to examine the patient, to have a full knowledge about the surgery, which covers entire CBM syllabus, entire requirement for any surgical student and also postgraduate as such. And always please again requesting, subscribe my YouTube channel. It is free for your increased knowledge about the surgery as such. So students, I hope you understood this lecture very well. Thank you so much.